I'm wondering if we have all the clinicians here. I see Dr. Arnold. Do you see Dr. Gilly? Oh, yeah. I have my reading glasses on. Thank you, Christy. Well, welcome back, guys. After a long day of presentations and excitement festivities of the weekend, we are the few that are left remaining. So thank you for being here, and thanks for our expert panel that's coming up, and are going to join us to answer our last few questions of the day. So I hope that you guys have brought some questions with you. One of the things that I wanted to start with, and I gave Melanie a heads up, is some of us here have participated in the eye study that she's done, and they've been looking at the data, right? It takes a lot of time to do data analysis, and so she was just going to take a brief moment just to kind of share a little bit about where that's at, and just kind of update us on that, and then we're going to start our Q&A time. And then if there's anything else the clinicians want to add too, that's fine as well. But.
Okay, so update on the LCHAD natural history study. So we thank you so much for those of you who have participated. We have 40 participants enrolled from age 2 to 36, so really spans the gamut. Everybody has been seen. I think we have 2 more visits at Pittsburgh and 1 more visit in Portland, and we will have seen everybody twice, so at baseline and 2 years later. So we're now looking at the rate of change, how have the eyes changed over time by genotype, how it's related to acylcarnitines, if it's related to hospitalizations in those 2 years. So we're in the process of looking at all that data right now. We've published several studies showing the impact of newborn screening and how much that has helped slow down the progression of the retinopathy. I'm working on a paper right now on the metabolomics and looking at those pretty volcano plots and how that's related to vision. Interesting, we have a short report that should be coming out in press pretty soon that many of you filled out surveys, and I appreciate that, where we were asking how the vision changes impacted your quality of life, your daily living, and we looked at those results and we compared it to the ophthalmologist, and you all will not be shocked by this, but the patient's perception of their vision matches the ophthalmologist's perception of their vision. So that was good to see that how they perceive their vision actually correlates with what the doctor is seeing in the eye. So the next steps, I'm working on a revision for that grant, and I hope to submit it in December. We'll find out in February and March if we're refunded, and I hope to continue to do another 5 years of seeing the same people forward and time again, so we can see longer how vision changes over time. In the meantime, we've been doing a lot of work that Shannon told you about on the basic science side, trying to develop in parallel a treatment approach that hopefully we can move into clinical trials. So that's sort of where we are.
I'm curious because you mentioned about it being long. If you could just take a couple minutes or whatever to explain a little bit about what's the importance of a longitudinal study? Like, how does that affect our community?
I think that the longitudinal study is really important. I think sort of going back to our very first talk when Dr. Vockley was talking about understanding the pathophysiology and the natural history of the diseases. So genes were mostly cloned and described in the 1990s, and we just started recognizing them, in the early 1990s, most of the disorders. So we don't have long-term data on outcomes. So the longitudinal study is really showing how things are changing over time, and so it's really critical data that we could potentially use as a control group. So let's say if we did get a treatment, the FDA is open to a really good natural history study in patients could serve as a control rather than having to do a randomized clinical trial. So they're open to that suggestion. So good natural history data that we collect now could help us move faster towards treating more people in the future. Now, the FDA could change their mind and ask for a placebo-controlled trial in the future, but I do think they are in discussion about having good natural histories in rare disease being the foundation of the control group in future treatment trials.
Thanks so much. I think it's really helpful for our community to understand, because like sometimes these studies, get thrown at us and it's hard to know exactly why or where they fit into the big picture of things.
And I'm sure you sat on either on those iPads or on that paper filling out all these questions saying, why am I checking all of these boxes? But it really was helpful information to say, yes, the patient is experiencing exactly what the ophthalmologist is seeing. And again, you guys could have told us that, but we now have physical data that actually backs that up.
Yeah. Questions? We have questions on both sides, so I'm going to give this to Becky and then Alex.
My question is for Dr. Neal, right? You touched on really briefly that during rhabdo, to avoid fluids with potassium in them. Could you talk about that a little bit more and explain why that is? Because we use body armor and we didn't know that. And
so I will say it's usually lots of potassium. So when you have too much muscle breakdown, there's potassium in the muscle cell, and too much potassium can be difficult for the kidneys to clear, or if you're having kidney function issues, then potassium is something that even can make it even more difficult for the kidneys to clear it. So I would say you don't want to get like IV fluids that have like potassium chloride in them if you were getting IV fluids. I think if regular like electrolyte waters or drinks have been working, I wouldn't change that. I would just say, like for the hospital, like usually not LRs and not something that had like nothing with the potassium in the IV fluid.
Okay, I'm looking for an answer to why on this, and all my doctors say I don't know. So hoping to get a different answer now. I'll throw it for y'all. So I've noticed some people's rhabdomyolysis, they can go in for IV fluids, and within a couple days their numbers have trended down and they're good to go. Even if they leave the hospital with their CKs still a little elevated, they'll keep trending down. For me, when I go in, it may be just a 3,000 CK, but it might take me 4 weeks to get out of the hospital. My CKs just trend down inch by inch, so frustratingly slow. Why? Would love to know what would be kind of a reason for the different types of response to the D10, the same solution, but different responses.
So I am not a kidney expert by any stretch of the imagination, and really the kidney was hard for me in medical school, but there are lots of different factors that play into an individual person and how their body reacts to kind of whatever the insult or whatever the trigger or trauma or kind of stressor has been. I mean, ultimately my answer is probably also I don't know, to be frank, but I think it's the same reason why, one person can get, the flu and have a fever for a day and then be fine, and other people, I think there's so many different things in the human body that we can't actually measure really well, or even if we measure them, it doesn't tell us what's different between two people. But I think knowing that is how you typically respond, or what your typical course is actually really important, because then you can kind of be helpful in telling the people who are taking care of you, yes, I recognize that it's going down really slowly. That's not unusual for me, because it's always, at least for me, it's always helpful if the person I'm taking care of can give me that feedback, because they know themselves better than I know them, so that we cannot be too worried or too surprised if that's the course that it's taking.
I
have a question possibly for both Doctors Arnold and Dr. Tsang. When, you know, the Lassie cartoon, I love it. But since I've been here, I have gained such an appreciation for what the parents as caregivers are going through, as well as the patients. And, you know, we do talk about therapy for chronic illnesses and family therapy and this and that, but in my mind, I'm thinking they've got so much on their plates right now. Can they even think about adding one more thing? Like, now I have to make appointments and go somewhere to add to all of this. Have you run across that? And I'd also be interested to know from the parents how they feel about that, and if they've managed to come up with an answer to get perhaps therapy if they want it and need it.
I think sometimes the child's illness can take up all the air in the room, and there's just not time, energy to put your own oxygen mask on first. I would say, if you can, try to enlist help. If you have family members that are nearby, if you have, let other people do things for you. Like, people don't necessarily want somebody in their laundry room doing their dirty underwear, but maybe you have to give some things up to try to make the time. And it's hard, especially because they're going to say, well, hire things out, hire the laundry out, but then you've taken a pay cut at work because you're absent so much. So it is really not easy. I guess all I can say is try to marshal as many resources to help as you can, because we recognize it's not easy.
And I would add to that, sometimes we think about therapy as the traditional way of you going every week or every other week. You sit down at the office and you talk to this person for an hour. It doesn't always have to look like that. For example, when I do a lot of inpatient psychology consult, the first time when I meet the family, it takes forever, like about 45 an hour, sometimes even 2 hours, because I'm trying to get the history. I'm trying to quickly get to learn this patient and the family really quickly. But the good thing about it is, for example, if we're expecting a 4 weeks hospitalization, now that they've established relationship with me, they can choose to see me once a week or as needed. There's a word I put on my chart a lot, is see psychology as needed. So we say, well, if you don't want us to come bother you because you're overwhelmed, okay, great. Just know that you're already established with us. So just let your nurse page us or have your primary team page us when you need us, right? That's one option you can always choose. Or some other people want to be like, oh, maybe come check on us 2 times a week. And when I say come check on us, it could be come in and say, hey, do you need anything? You don't? Okay, bye, right? That could be what you request. Or it can be, well, I want a 15-minute check-in, right? So depending on who you work with and where you are, you can really communicate with your support, whether a social worker or a psychologist, and let them know what you need and when. And of course, I can't always, if you tell me they want to see me every day in the hospital, a lot of time I can't because I'm running between other floors and seeing other patients. But if you're asking me to scale it a little less and see you when you need me, a lot of time we can make those accommodations happen. And the other thing about, even if you're not in a hospital, and if you're already established with a therapist outpatient, depending on your therapist, a lot of time we want to be flexible. So sometimes we may do a video visit instead of you having to come in. We may do a phone check-in. I've done a 10-minute phone check-in with somebody instead of, again, having a full session. You can ask, hey, I've been very busy. Can I do every month session instead of every week session? So there's a lot of options out there to make it fit what your circumstances.
I would second all of that, and this is my chance to plug Mito Action's Friday every weekly support calls. I haven't taken part in those a lot, but Mito Action does do a weekly support call. So if therapy is just like, I get it, like too many appointments already and don't need to add more, finding community in Mito Action or even in your local community is great. So the times I have called in, that's been just, it's just helpful to talk to other people that get it, you know. So that's one option too.
I'll just say really quickly too, as a therapist, most therapists are really open to being flexible. And so if you can find times that you already have time away, like if you're sitting in the carpool line for 40 minutes, you know, your therapist might be willing to do a telephonic session with you, so you're not trying to find another hour in your day. Or when the baby is sleeping, you're like, hey, can you talk now? Or you're, you know, washing dishes or whatever like that. So trying to find time that you already kind of have alone time that you can squeeze it in, but finding therapists who are flexible, and most of them are. As far as financial, a lot of our parents don't work, but maybe one parent works. I would utilize your EAP too. Most employers over 50 people have employee assistance programs, and that provides up to 4, 6, sometimes 12 free counseling sessions. There's no copay, nothing at all that you pay. So that's another benefit that people can take advantage of to help with the financial cost of getting therapy.
One thought I had is I feel like it's still growing and changing. I had a great opportunity to talk with Dr. Tsang a little bit just about even child life that I learned with Alex. It's a growing field. I think this whole area is growing, and I think that one benefit we may have, and I say that may because I think it's still growing in our role with Mito Action. Much like our journeys are changing, I feel like there are some strong seasons of great demand on us as families and some lovely seasons of plateau. And so it's gonna, I think our from our experience, our FOD journey has been quite varied in different seasons of life. Probably we should have all been checked in many decades ago. But I do think that there's more and more, and I think that I'm really excited about the fact that we are connected with Mito Action, and that there are support, there are places to go now that you can, that our kids can talk to people with other disorders, that they can do that. And us, even as parents, I think there's a new space, and I think it's growing and changing. And I know that just being on kind of a back group that I'm in with Stephanie, that's part of what we're talking about, what else needs to be in this space. And I think, one, identifying resources and making them available. Two, identifying places where people can connect virtually. And then, of course, this, you know, let's face it, moms, this is one giant therapy session for 3 days. So, I mean, it is, because when we are connected, we feel seen and heard well. But I do think it's growing and changing, and I think if you need it, talk to either your FOD mom friend or dad friend, or reach out to Stephanie or Kyra, because they want to put things in this space. But I don't know what you need, and neither does Stephanie, and neither does Kyra. And we have amazing, amazing professionals. You are knowledgeable in this field, and it's wonderful to see that. I feel like it is changing.
I would say to really embrace that your mental health is more important than what other people think of your housekeeping. You know, when people say, "What can I do to help?" have an answer. Don't think you have to do it all yourself.
I think that's really wise, Dr. Arnold. But that was like a slide that I went ahead and I clicked a picture of that, because I think sometimes when you get in crisis mode, you know, it's like you're just in that mode. You don't even remember what needs to be done. And sometimes you have like that friend who like can like come to your house and be like, you know what, I can just help right here. But then when other times you don't, but people say, oh, if you need any help, just let me know. But in that moment, it's so hard to think. So like if you can like write those things down, I actually have a list written in my journal. So when the time comes and somebody asks, I'm like, I don't know what it is I need right now, but let me go find that list, you know? So I think that's brilliant. I think it's,
Yeah, I know when I broke my leg and people said, well, what can I do to help? And like, you could walk my dog, you know, because I can't do it. And yeah, it just have an answer. And
I have
think you
seen
have to do
people
it
ask
yourself.
neighbor mow their lawn for them. It's okay. People love to do that. Like walk your dog, mow the lawn.
I had an easy question, maybe. It stemmed from the pyramid, or the document that was talking about the incidence of LCHAD, and I was wondering if we knew updated what was the odds that you were a carrier of these diseases. I think 10 years ago I was told it was like a 1 in 300 chance that you were a carrier of LCHAD. I don't know where I would even look to see if that's been updated?
That's a great question, Christy.
It is a great question, and I'm racking my brain to come up with the right number, Christy. I think that the numbers have not been updated super recently, and I believe carrier rates are in the United States are still about 1 in 300,000. But I might know where I can go look to see if anything is more recent. Yeah, 300. 1 in 300. That might be true for carriers. I think the incidence rate is like 1 in. Yeah. Has LCHAD, right. I would have to do some hunting. I don't know those numbers off my top of my head, but I don't know that they've changed significantly since the last time you saw them.
Well, if you take the square root of the affected frequency and multiply it by 2, that's the carrier frequency. So if it's really 100,000, what's the 1 in 100,000? With LCHAD? Oh, I thought it was more like 1 in 100,000. If you take the square root of that and multiply it by 2, that's the carrier frequency.
Okay. So all right. Well, I'll do the math and we'll confer. But
Don't
I know
forget
exactly.
to carry the 1. Really important.
Actually, the population genetics, it's a binomial expansion, and it's on the boards. I have to know it.
Well, the teens back here have a question. They sent Sharika and I on a race, and I won, Sharika.
I didn't know we were racing. I didn't see.
All right, what's your question?
What's the difference between CPT2 and LCHAD?
Good question.
Who wants to start it? Okay. The way your body breaks down long chain fat is it esterifies, which is a long word for just gloms onto the fat with carnitine. And that pulls it into the power plant of the cell, which is the mitochondria. And then it gets released, so now you have the fat
Mike, a
inside
little closer.
the mitochondria. There you go. Oh, now you have the fat inside the mitochondria, and then the enzymes can start breaking it down. So CPT1 is the enzyme that attaches the fat to the carnitine. The translocase pulls it into the mitochondria. CPT2 is the one that releases it from the carnitine so that it can be metabolized. And then the LCAD and the VLCAD and the LCHAD enzymes are just subsequent steps in the breakdown of the fat. So they're just consecutive steps in the breakdown of the fat. In terms of symptoms,
I think he's asking the difference between LCHAD versus TFP.
Oh, no, he said CPT2, because his buddy over here, I think, has CPT2, and he has LCHAD. But maybe I'm reading too much into
gotcha.
it. Let me take the mic back to him in case for
Okay.
clarification.
CPT2 was, okay.
He said yes.
Yes.
Yes, he wants to know the difference between CPT2 and LCHAD.
Well, you're right.
You're doing a good job. You're doing a good job.
Okay, yeah,
You
so
said
there-
in symptomology.
There's subsequent steps in the breakdown of the fat. In terms of how they present in people, they all have quite a bit of variability. So the really, really severe CPT2 can present in an infant who is so sick they just can't make it in the world. Or it can present in an adult who suddenly starts having trouble mowing the lawn when they've been fine their whole life, and there's everything in between. And the LCHAD is, in some ways, the same. There are some babies who are just overwhelmingly ill right at birth, and then there's people who don't get sick until they're older, which we used to call mild disease, but I think now we're going to have to call it late onset disease. But in terms of, they're all basically just steps in the pathway of breaking down fat and getting energy out of it.
Other questions?
I have a question. Dr. Gillingham, you talked about in your supplement talk, at the end, I think we had talked about DHA supplementation, and you were saying that something about doing a DHA specific versus just like a general fish oil or something, because then it give you too much of what your body doesn't need. I just wanted to make sure that that's what you were saying, because we just talked to our team about maybe supplementing for Canaan DHA, and she's like, oh yeah, you can just get any fish oil. And so just now that you talked, I'm like, wait, should I be looking for a DHA specific supplement, or is fish oil, like something like that, okay?
Well, so there are differences of opinions, Sharika. So some people might just say to use a fish oil. The DHA is more specific. So I think you can do an algae-based DHA and add just a very, very tiny amount of fat. If you do a fish oil, most capsules are half to 1 gram, so you're adding a gram of fat to your diet. If you take a DHA algae capsule that's 200 milligrams, that's 0.2 of a gram of fat. It's a tiny amount. So you're getting exactly what you need without a lot of the other stuff that comes with it.
Okay, we'll go that way. Thank you.
I have a question from the eye study. Will there be some sort of thing from the eye study that comes out that we can present to our physicians, our optometrists, or optometrists, whatever they're called? Whatever. It's been a long day. Because I'm having trouble describing to the people what is happening, because they cannot look through my eyes like I am.
Right.
And so is it even for parents and my family, for them to understand? It's hard.
Understood. Yes. We're working on putting together a summary for each individual participant that will have your baseline data and then your 2-year data and what changed, along with acylcarnitine data, and then we will email that to everyone. I think Ashley, my study coordinator, would prefer to do email versus snail mail, but we will get out individual results as well as sort of an overall summary of what we found in the whole population. So we are starting to work on that. I first have to write up an outline and get it IRB approved, and then insert individual stuff after IRB approval. So it may take a little while, but we will get that to you.
But in the meantime, there's some medical journal articles that you've published that
Yes, we
if
have.
you want to take to where can she find those?
That's a great question. I think we have links on Gillingham, if you just do Gillingham Lab website.
I thought so too, but I wasn't.
Yeah, I think you can
100%.
get the links to the actual published manuscripts on our website. And if you sign up on Ashley's notification, we have a newsletter that goes out every 6 months that get emailed to you, and she has links for publications in those newsletters as well.
Okay, so you may not know the answer because his doctor didn't know the answer, but the number one way that I can tell that he's in rhabdo is he's screaming that his eyes hurt, but that's all I get. So I don't know, or he's just saying eyes, my eyes. So I don't know, does he have blurry vision? Does he have a migraine? Like, do we know what's going on? Have you heard of that before?
I confess I haven't heard that before. How about you?
I haven't either, and unless it's the eyes or the muscle, like his extraocular muscles that are inflamed, but they're pretty small, so I would expect that there'd be some, like somebody would be able to see that on an exam if he would tolerate it, but I don't know. And it's been like confirmed rhabdo when that's been what he's screaming about?
Yeah, that's the only time he ever cries about his eyes. So I always take him, and it's always like 30 to 60 or more CK level. So, yeah.
I don't know, but I will keep that in the back of my mind for if somebody asks me if that can be a presentation of rhabdo, because before today I would have probably said no.
Okay.
I will
Thank you.
keep that in mind.
Other questions or insights for the docs? And if you're raising your hand and I can't see it, I don't have my distance glasses on, just let me know. Yep.
So I have another question about, you talked about rhabdo and what constitutes rhabdo and what doesn't. So like our kiddos sometimes will wake up in the morning and just be kind of sluggish, maybe have a little bit of neck pain, but not bad, and say like, I just need to take it easy for the morning, and they'll have breakfast and let those calories kick in, and then they're fine for the rest of the day. Maybe they have to take it easy and they're not gonna like go run a mile or anything, but would you consider that rhabdo? And we're not doing a CK test at that point because, you know, they can treat at home and they're fine, but when it comes to like actual neck pain that's not in a typical muscle group, you know, what constitutes rhabdo?
So I guess there is the medical definition and, you know, laboratory results that would say, yes, this is I could diagnose this as rhabdo. And then I think there are the symptoms that someone experiences. And to some extent, if you're able to respond appropriately without medical diagnosis and it gets better and you don't have any ongoing problems, I would probably say that may be the experience of rhabdo for that person. But to some extent, I don't know if it matters, unless there's like urine color change or the things are not getting better with like conservative management, like, or the person can't take in enough fluids or enough calories, and then I would say you need medical attention for the rhabdo. But I mean, I guess my other question would be, could it have just been the person didn't sleep well and slept funny, and that's why their neck hurts? But it's hard to say.
The reason I ask is because, you know, our clinician will ask like, what are your incidents of rhabdo since the last time I saw you? And I don't want to blow it, you know, sugarcoat it, thank you, or anything, but I also don't want to like make it into a bigger deal than it really is. So I'm just trying to always gauge about what do I say as far as like what is rhabdo?
I mean,
some of our patients who are on home therapy and have home health nurses who come draw the CKs, they will wake up and they say, I'm a little sore today. I'm not having, you know, I don't feel like full-blown rhabdo. I'm not in acute pain anywhere, but I just feel a little sore today. And if they get their CKs done, they might be 1,000 or 2,000, and they may, in fact, by taking it easy, be heading something off at the pass. And so do you call that rhabdo? I don't know. I mean, I'm not sure that there's a definition of a CK, you know, that if it's 1,999, it's not rhabdo, and if it's 2,000, it is.
I have something to somewhat add to that. Probably in the last like 3 months, I was talking to another VLCAD mom, and she was talking about how her daughter always takes longer to get up. And I've noticed that Alexis will get up and she'll be like, oh, I'm so old. And I'm like, you know, like I roll my eyes at it. But the more I was talking to her, the more I was thinking maybe this is LCHAD specific and it's her like rebounding after exercise. And so every day I'm like, no, she doesn't have any issues with her LCHAD, but maybe she does, and it just presents in a way that I've never noticed. I'm like, you're 13, like, we'll talk about getting old eventually, but yeah, she'll be like walking down the hallway like, I'm so old, my back hurts.
Well, that's interesting that you say that, because when Chris, when we started understanding rhabdo and the clinicians were explaining to us what this was, you know, they talked about the leg pain or arm pain, and that was it. And then I was reading about rhabdo and noticed, oh, but lumbar pain like can be a symptom too, and that was never discussed. So I went back to and was like, hey, is this a thing? Because he would always complain when he was younger of his lower back hurting. And they're like, oh yeah, that can absolutely be a sign of rhabdo. We just don't think of it because we just think of legs. And I'm like, oh, but that's really important information because there's these other parts of the body. And so that kind of leads to another question. Are there other parts of the body? I mean, it's interesting to hear about, like, you know, how your child's eyes are affected. You know, I mean, when you, like, as a clinician think rhabdo, like, is it mainly just arms and legs, or do you also mention, like, lumbar or neck, or how do you go about that?
So I'll be honest, I'm not the person that usually sees the patient first thing. Since I'm a neurologist, I see them afterwards, like in the clinic. But I think it depends on the cause of the rhabdo. So I would say if for people who have a metabolic reason, I think it could happen anywhere because it's your whole body is what's trying to, metabolize and get energy. I think for people who are getting rhabdo from overdoing it on physical activity that don't have like an underlying metabolic reason, I think of like the quads and the calves and the biceps and deltoids, but I would say it could, that's why it doesn't surprise me, or I mean it does, but I'm gonna have to think about it being in the eyes, and I think like if you do a whole bunch of sit-ups, like you could totally get rhabdo in your abdomen or in your abdominal muscles. So I think the general population would think, or most doctors would probably think of legs and arms, but there's nothing to say it couldn't happen in other parts of the body.
I would say most of the frequent flyers I've seen, the kids who have a lot of rhabdo, learn when they're just a little sore and when they're going to have to do something about it. For the patients who aren't, where they've done something, I find cold stress is hard on the patients. And I would see a lot of kids after they'd spent the day running around in a water park. And it's more of an unusual event, and they usually have pain everywhere. But yeah, I guess I would say rhabdo, rather than being an all or none phenomenon, is they probably have a little bit of muscle problem going on, and it might make them a little sore, but not sore enough that I'm worried about their kidneys yet. But I find the kids who are frequent flyers can usually tell us when it's bad enough we need to do something about it. Could I ask you a question? Sure. In the olden days, we always said that you should put bicarbonate or alkali in the patient's IV fluids. And then the literature said, oh, it doesn't really help. But yet, when the patients come in, the hospitalists always add bicarb to their IV fluid. What is the thought on that?
I don't know, but I also have read that I think that's like the protocol. I don't know if it is, I don't know what the scientific basis of that or why it doesn't work or but why they still do it. I don't know. I would have to phone a nephrologist friend, to be honest, to get me that. I think the other thing as a person who asks patients about their symptoms and, how have you been since I saw you last, I think it's totally fair to say we've had an episode like this many times and this many times, so that, because at least when I take a history or I'm taking information from families, I put that in. It's kind of, to say to some extent, it's kind of how I ask about headaches, if my patient has headaches, because people will differentiate their migraines from their headaches. And so I will use their words in my notes so that I have the next time, okay, how are these episodes it's kind of like as well with seizures. I mean, I'm talking about things that I see in clinic as well, but like seizures, people can have different versions of their seizures, and I think different versions of muscle pain, soreness on the rhabdo spectrum.
I have to say, when I first got to Pittsburgh, I was in church singing in the choir on Easter Day when I got a phone call about a patient who was home with a CK of 60,000. And I was like, you what? And I called Dr. Vockley and I'm like, what is this? And you didn't tell me and warn me there were these patients at home? But he was such a frequent flyer that he had no life. It was in the hospital all the time. And as long as his potassium and things were okay, he was getting IV fluid with home nursing. And yeah, but I would have appreciated being warned. I could have killed him.
I'm going to blame you. Ollie and I were having a conversation here about rhabdo, and hearing everybody's comments, it triggered way too many things, and I got to open my mouth. Because things like feeling old about getting out of bed very, very easily could be rhabdo. Here's how I think of it as a layman's term. I don't know even 1% of all the medical super smart people up there. God bless you. I'm just a layman on this stuff, living through it for 35 years. But 35 years of it, you learn a thing or two. I think of it this way. For 15 years when I was a kid, I was very sports and active, and I wasn't symptomatic. And then life stopped at age 15, and it was, oh my goodness. So I know the difference. So rhabdo, think of it as like you accidentally ran a marathon, and your body's got to repair from it. And what happened when you overexert? Your muscles get stiff and sore, and you got to deal with that. And maybe you feel like an old person getting out of bed in the morning, even though maybe you're 11 years old. And lower back pain. I have to have a double epidural into my, L4 vertebrae to be here. Otherwise, I'd be flat down. And guess what I travel with? You see this silly thing to the bottom of my backpack? I roll out my IT bands every morning in my spine. This is how I get through my day. Otherwise, it doesn't happen. We look healthy, but inside, chemically and what's going on, it's malfunctioning out the wazoo, and we got to push back. We got to hold back the tide and go to PT and learn things from the PT people, get the equipment that they recommend, the things that your body responds to favorably. We got to push back against these things because the tide is coming in. You got to hold it back however you can hold it back. That'd be my best recommendation, but I hear all these things is it this, is this? I'm thinking it's all those things, guys. Yeah, it's it. It's that's what's going on. Thank you so much for listening to my silliness.
I think that brings up an excellent point as far as I think there's a lot of commonalities that as we talk with each other, we're like Christy, you were talking about the old man. Sam is the same way. He's like, I feel like an old man. He's like, what is wrong? And delayed processing speeds, we see all this stuff, tight heel cords, tight hamstrings. I think it's wise to pay attention to when, they start to complain about, these things, because that's, for an 11-year-old to say that, I think that we definitely need to just kind of think about that as far as commonalities and how do we get these kids to continue to thrive? How do we give them the best quality of life? So, but okay, now I'll get off my soapbox. But I have two questions. Oh, go ahead. Did you want to say Dr. Gillingham?
Yeah, I was just going to say that. So one of the things I'm hearing is we talked about in our clinicians panel, we haven't captured this well. We know it's happening. I hear you telling me about these episodes that maybe are not full-blown rhabdo by a medical definition, but are still impacting. And so we're submitting a grant to try to pull together a consortia. And we want to try to capture these things, but I will need your input and help to know what instruments, what surveys can capture what we're describing here, which is maybe not a CK that I need to go to the hospital for, but some sort of muscle pain and how that impacts whether you can go to school or how much you can work or whatever those things are. We need to somehow figure out how to capture that information so that we have a better descriptor than what we're throwing around right now. And I think a longitudinal study that we're hoping to fund and launch in the near future would be a great way to do that. And I'm going to be relying on you guys to tell me if those instruments do capture what you're explaining or are off base and we need to look for a better tool to capture that information.
No, I think that's great. One thing too that I've just kind of been thinking about is just looking at symptoms. I was wondering, it seems like kind of like almost advanced aging, thinking about the eyes, as we all get older, we lose the night vision, and so it just seems like it's accelerated sometimes. Even just the stiffness, the IT bands, that those are, as you get a little bit older, and for some reason, I feel like we see them a little more common in our population. So I don't know what that amounts to, but yeah, that'd be great if we could, because I know y'all are on our side, and so we love you, and we really appreciate you being here and just listening to us and letting us listen to you, because that is the community.
Thanks.
And Dr. Neal, I had a question for you. Okay, sorry. You had mentioned you work with some clients that are not metabolic but go into rhabdo. And so did you see our CPK meter that we're trying to get funded out there? Because that's one of the things I was talking to him about is are there other patients that could use this? And so,
yeah, so I think the most common thing that I think of when somebody, comes to see me or is referred because of an episode of rhabdo, if it's not a situation of, they're 5 years old, they got the flu, got a really high fever, that caused the rhabdo. Usually if I know, like they've had a newborn screen, so I know they don't have certain things, I will usually kind of say, this is what I would recommend in the future. But I usually say more than one of those kind of episodes. I'll offer testing, like RYR1 is kind of the first thing I think of. It's a gene many people probably know, but it's a gene that is highly, there's lots of different changes that can be seen in that gene, not all of which are problematic or actually disease causing, but it can make anesthesia really dangerous for some of the people. And so like that, and then there's kind of a whole panel of genes, but or sometimes somebody presenting in rhabdo can be the first presentation of a muscular dystrophy as well. So, and I think that is a large part of the patient population I take care of. So that's usually where my mind goes. But typically their CK level never comes down. Like it stays elevated because that's where they live. So it kind of, so yes, there are probably, I have patients who have muscular dystrophies who are strong enough that they do enough activity that they can put themselves into rhabdo. And for them, I think they usually know by symptom, not necessarily, they don't need a CK. I mean, they do when they get to the hospital, but they aren't able to handle it at home because it doesn't happen often enough for them to be able to handle it at home.
I have two things I wanted to say. So first off, that old man feeling I have, it's really funny that multiple people have said it because I actually have said that before. I'm just like I remember specifically a time where my dad, who is 61 years old, got up from the couch and I got up at the same time and we both groaned. And I was like, oh, man, I'm like an old man. But the good thing is that is like episodic, so it passes, it comes and goes. So it's not an old man as in like this is permanent. I think it's just it comes in waves, and it's just a matter of accommodating for it when it comes. So I'm happy that you said something. Another thing though, Dr. Gillingham, you mentioned the questionnaires, and something that I think might be helpful to you guys is whenever I do the questionnaires for any research study I've been in, I always find myself sitting there looking at it and saying, how have you felt in the last week on a scale of 1 to 100? And you're just like, I'm fine right now. I don't know how you don't think that hard about it. I think it would be more beneficial to have kind of like a diary of like throughout the week or throughout that month every day, just know, are you in pain? Where are you in pain? And just kind of like average it out and see how often it happens and get a value from that. Because just asking from the past is kind of hard, especially when you're when you're feeling good, you're trying to forget about the time you're feeling bad. So, I feel like it's not very accurate to ask those kinds of questions.
Well, you're reading my mind. So one of the ideas we have in the grant is to put together a symptom log that would be just like a paper you get up in the morning and yes, I'm feeling pain or whatever. And I was hoping we could try to model it off other diseases that have symptom logs, like a migraine log or something like that, and establish that and have people keep track so that we can capture that kind of information. But I'm open to other ideas if you have some ideas. But that's one of the things I thought about.
Well, let me tell you. I'm on the PKU consortia study of phenylketonuria, and one of the things we did for our pilot projects was this. Emotional momentary assessment, EMA, and it basically sends out a text to the participants in the study saying, how do you feel right this minute, and they answer it. So and that seems to be pretty accurate, so that might be something you could use.
Dr. Gillingham, I would say to you, the My Mito Action app will do that for you. where they can track that throughout the day. They can track the symptoms, and you can see the longitudinal results of what they're
Perfect,
putting
we already
in.
have something.
Right.
Yes.
So the My Mito app will do that for you,
I've had a little bit
and
of
that's data
trouble
that
with
we can share with the clinicians.
I've had a little trouble with the app. I don't know if it's me, but we'll talk.
We'll talk about it. Yep.
Yeah, definitely. You know, I'm more than happy to share all the information because I'm always reading them, and I'm just like, I see so much potential here, but I just can't write it because there's no box for it. Yeah, good luck.
Okay, 1.5 questions. So thinking about rhabdo as it relates to strength training and sports and things like that, how do you know or gauge when you're headed into rhabdo and you probably need to pull it back, or this is a new sport, like Kanan's gonna be playing football in the fall, so pray for me because I'm terrified out of my mind. And like it'll be a new sport for him, working new muscles, things like that. My husband's like doing drills with him now. He has a whistle, he bought, so they're doing the whole thing, right? Some of that's new because he will be new to this sport. So he's gonna be sore. It's gonna be, how do I know it's just that? And like, okay, yeah, we'll fuel you up like we normally do when you're exerting yourself, but we can keep going with your training tomorrow. Or, you know what, this feels different. This may be rhabdo, let's pause for a week or whatever. Do you know what I mean? How do we know that difference?
So I think the fact that you've already started the training and kind of already, because I tell people it's embarrassingly slow how slow that slope is up of gaining physical activity. So I think that is one way you can probably prevent the rhabdo or make it less likely if you're already doing the things slowly or introducing them and it's not nothing and then camp starts on Monday and you're going for 12 hours. So, I think usually it kind of depends on the individual person. If a typical workout is, like he knows I feel sore for this long, but then if I've done a normal soccer practice and then the next morning I'm fine and the next morning he's not, I think I'm a huge believer that like patterns are key. Like if something doesn't make sense for your child or for you, then it probably means something. And if it doesn't feel right and it's not getting better like it typically does, then I think it's probably worth investigating it. I can't tell you for sure to go to the ER, but if it's just not, something is not right, I feel like I tell my families, I trust your gut, like you have to trust your gut.
Right, okay, thank you.
Like you'll see it, you'll know.
When they bounce back faster, if it's
Like they'll either bounce back or not. Like when it's like
Okay,
sport related, you'll give them a snack, they might take a nap, they'll wake up fine.
Right, okay,
You'll know.
gotcha, okay.
I had a question, it's kind of two questions, I guess, but one is, can or could blood sugar monitoring or testing be used to understand or offset when rhabdo is going to happen?
My gut reaction is no, because I've had people in rhabdo and their glucose never dropped.
Okay.
So the plasma glucose did not necessarily reflect what was going on in the muscle.
Yeah, when I was training, 150 years ago and rode my horse and buggy to the hospital, we gave all the MCAD families glucose monitors, and then we began to realize if you're heading down, you need to come to the hospital. You don't want to wait until your glucose drops. And most of I don't think I've ever seen hypoglycemia in a
the rhabdo
patient.
episodes are not associated with hypoglycemia, at least in my experience. So I don't know that the glucose monitor helps.
Okay. Yeah. And the second one's more dietary, and I think I spoke to it when I gave my presentation. But in his book, Dr. Will Bulskowitz, Fiber Fueled, references that 10% of your calories can come from having adequate fiber in your diet and the fermentation that happens in your small intestine. And specifically, those end up being ketones, which are small chain fats, which are very important to brain and heart and other organ function. So is that worth looking at for this group if it's a secondary metabolism that can be 10% of calories and it's short chain fats? Should we be more aware of fiber and considering whether we have enough of it in our diet, considering that most Americans don't?
Well, for all the reasons you just said, I think it's a great thing to look at, and I'm all for a more fiber in the diet. The problem with measuring short chain fatty acids, I mean, it'd be great if we could prove it, you know, with a blood test. They're highly volatile, so when I draw blood and I try to measure the short chain fatty acids, they've already sort of released from the blood as a gas, and I can't capture them. But absolutely, we eat less, too little fiber, and absolutely it can provide short chain fatty acids and ketones. So we talked about ketones as a potential treatment, and you could naturally make them by fermenting fiber in your colon.
Yeah, the two things that give you satiety are fat and fiber. And so if you're eating a low-fat diet, it's actually very helpful to eat fiber just in terms of your satiety and your feelings of well-being. Now, as I had said before, a lot of our kids with long-chain fat defects just kind of have developed disordered eating, some of which is innate to the disease and some of which we did to them. But fiber is always a good thing.
I wanted to answer your question regarding how you're gonna know. I usually try to prevent. I work on prevention before, so what I would do, I'll just hydrate and give maybe more Gatorade ahead of time. So when he go do the sports, he will use those simple carbs instead of start breaking down the muscles. So I'll just load him before he goes. He used those, and most of the time it will work. Yeah. You did? Okay.
Good. Last call for questions. Oh, down here.
Hi.
One more.
So if the lowering of his glucose has never been a problem up until this point, is it something that can pose a problem in the future, or can we expect to not have issues with that?
I would say yes. I would keep close eye on it until he's a little older. I find, and Georgianne can confirm that, so the hypoglycemia I would just watch for until they're about kindergarten.
Yeah, so as you get bigger, your liver can hold more glycogen, your muscles can hold more glycogen. It gets to be sort of less of an instant problem, but it doesn't mean it can't happen. But the other thing that's happening while your glucose is dropping is that your acylcarnitines are building up, and they're toxic too. So very often the older patients are sick, but they're not hypoglycemic. I think that's one reason why we've kind of more gotten away from glucose monitors, because you can still be quite sick before your glucose drops.
Did that answer your question? Yeah. Okay.
For the eye study too, that y'all had kind of touched on it, and you touched on it last year, but like the accumulation of the metabolites, especially with fasting and LCHAD, you know, as you start to enter puberty and pre-puberty, I mean, do you have any thoughts as far as like when do those metabolites kind of start accumulating, and you know, the midnight snack thing, and like how does that look? Is that a fair question?
It is. So we published a paper that looked at it. So I think of acylcarnitines for all the diseases that we're talking about as opposite of glucose. So when you wake up in the morning, you're fasting, your acylcarnitines are high, and you eat breakfast and your glucose is low. And you eat breakfast and the glucose goes up and the acylcarnitines come down. They start rising before lunch. You eat lunch, they go down again. So they're doing it up and down all the time. I don't have data to know that it's different in a little bitty guy versus an adolescent versus an adult. But I do know that they do this up and down. And the study that we published that in, it was everything from 7 up to 50 something. So we know the acylcarnitines are going up and down, and if you exercise, they go up. So all of these physiological changes are moving your acylcarnitines all the time. So I don't know how they change with age. We need to study it and see if it changes with age. I don't think so. I think it's pretty constant across the lifespan that they're doing these up and downs. but it has to do with physiological state. So one of those ideas of not fasting for a long time is what's really going to suppress the acylcarnitine is probably the best.
Yes.
Okay, last call for questions. That's it? All right. Well, I had this long closing that I was going to deliver, but I think everyone's tired. So I am just simply going to say thank you. Thank you to all of our doctors, all of our speakers, all of our sponsors, and most importantly, thank you to you for entrusting us to walk with you on this journey. So we are going to go back. I think we've had an amazing weekend, and our team is going to go back. We're going to send you guys a short survey to answer some questions about your experience this weekend. But I think the consensus is if they will have us back, that we may be back here next year, bigger and better, with some more fun activities and continuing to grow, you know, with the goal of maybe filling this room one day, right? So I want to give a special thanks to Jim Davis up in the box. He's been behind. Jim is the director of Fine and Performing Arts here at Country Day, and our kids went to school together. And just, Jim, I can't thank you enough for all you've done to make this possible. So thank you, everyone. Safe travels home. Please keep in touch with all of us. We're here for you. Reach out, Stephanie, me, Susie, Emily. We're a small but mighty team. So definitely reach out to us. Stay in touch. Let us know what you need. Let us know how we can continue to support you. And most importantly, stay connected to one another. That's why we do this, so you know that no matter where you go on this journey, you have a community of support. So stay in touch with each other, stay in touch with us, and we look forward to seeing you again next year. Thank you. You'll see on the screen some of the photos from this weekend, so enjoy.